Hello everyone, my name is Cheyenne and I will be talking about the challenge of breastfeeding a baby with Down syndrome while the mother has mastitis. To guide this presentation, we will be following the story of Sarah and Lily. You are a perinatal nurse working on the obstetrics unit of a rural hospital. A woman named Sarah is admitted with mastitis. She gave birth to her baby Lily 3 weeks ago. Upon delivering, Sarah was surprised to find out that Lily has Down syndrome. The dyad had trouble with breastfeeding initiation, so a lactation consultant was previously involved. I will be using the Situated Clinical Decision-Making Framework adapted from Gillespie and Peterson. The framework involves knowledge, cues, judgment, decisions, and evaluation of outcomes. This framework is meant to guide decision-making within nursing by clearly outlining salient information. We begin by looking at our knowledge about the issue. So what do we know about mastitis? Mastitis is the inflammation and infection of breast tissue. Symptoms include a warm reddened area to the breast, localized pain or tenderness to the breast, and flu-like symptoms such as malaise, fever, and headache. If mastitis is not treated, the woman may develop a breast abscess, chronic mastitis, or fungal infections to the breast tissue. Although mastitis can occur at any time during breastfeeding, it is most commonly seen within the first 6 weeks. Mastitis can be caused by bacteria, usually E. coli, Staphylococcus, or Streptococcus. The bacteria often enter the breast through damaged or cracked nipples caused by poor latch. Mastitis can also be caused by inadequate breast emptying. This could be due to a weak suck, ineffective latch, or abrupt weaning. Stagnant milk provides a warm, moist environment for the bacteria to grow in. Also, plugged ducts, a tight or ill-fitting bra, breast trauma, stress, fatigue, and maternal or family illness can contribute to mastitis. What do we know about Down syndrome? There are 3 types of Down syndrome. 95% of people with Down syndrome have trisomy 21, where all cells have an extra chromosome 21. People with Down syndrome usually have cognitive and developmental delays, along with telling physical characteristics. These characteristics include upward slanting eyes, a flat facial profile, a large protruding tongue, small ears, simian crease, which is a single deep crease along the palms, and low muscle tone, just to name a few. We must also be aware of the advantages of breastfeeding a child with Down syndrome. La Leche League International states that breastfeeding provides extra protection against infections and bowel problems, which are more common in babies with Down syndrome. It improves tongue and mouth coordination and strength, provides additional stimulation for the baby, and promotes attachment. Now we move on to cues. What will you assess for? For Sarah, you want to determine if she is having breast pain. Is there a red, warm spot on her breast? If so, palpate the area to assess for an abscess. You want to look out for signs of infection, such as temperature, heart rate, and blood pressure, along with labs such as white blood cell count. Assessing her nipples for a portal of entry for bacteria is also important. It is a good idea to ask Sarah what kind of support she has at home as well. For Lily, you want to assess her sleepiness, as babies with Down syndrome can be difficult to wake for feeds. You also want to check for tongue protrusion, as this can impede latching, her output, her weight gain, signs of infection, and her muscle tone. It is important to keep in mind that babies with Down syndrome gain weight slower than babies without Down syndrome, and there may be a specific weight chart available to you. As for breastfeeding, you want to assess Lily's ability to latch, taking in a full mouthful of breast rather than just the nipple. You will also assess the strength of Lily's suck, the frequency of feeds, and signs of milk transfer. You want to make sure that Sarah is fully emptying her breast with each feed as well. Also, assessing for pain during feeds, along with the dyad's breastfeeding position is important, looking for full support of Lily's head and neck. Upon assessment, you find that Sarah's right breast has a large red area that is warm and tender to touch. There is no lump. Her nipples are dry, and her right nipple has small cracks in it. Her vitals are normal, with the exception of a temperature of 38.1 degrees Celsius and a slightly elevated white blood cell count. For support, Sarah has her husband and mother. Lily is very sleepy and hard to wake for feeds. Her tongue protrudes when latching. For 2 days, Lily has been having 4 wet diapers a day and 2 dirty diapers a day. Sarah usually wakes Lily every 2 to 3 hours to feed. Lily has a weak suck and tires easily. Sarah experiences nipple pain when breastfeeding, and Lily appears to have a shallow latch. Next is judgment. This is where we ask what could be happening. Lily's sleepiness and tongue protrusion can cause a poor latch. This poor latch, then, can cause cracked nipples, which are a portal of entry to bacteria. This causes mastitis. On the left again, Lily's weak suck and low stamina for feeding, along with the poor latch, can decrease milk intake. Low milk intake can cause Lily's low output, as well as Sarah's breasts not being fully emptied. If milk is left in the breast stagnant, bacteria can grow, which causes mastitis. What are the priorities for their care? First, you want to ensure an effective latch so Lily can receive enough milk for growth and development. Second, you want to promote regular breastfeeding and ensure Sarah is fully emptying her breasts. Third, you want to continue assessments to ensure the mastitis is being resolved. Now, how can you help with the latch? First, ensure a comfortable position. Sarah should be supporting Lily's head and neck, keeping her spine aligned. Since Lily tires easily, the dancer hold, as seen in the picture, may help conserve energy. For this, the mother uses her index finger to support the baby's jaw. Sarah should feel more of a tugging sensation instead of nipple pain when breastfeeding. For Lily's sleepiness, stimulating her senses can help to rouse her. Talking to her and touching her limbs can help. Using a cool cloth on her tummy promotes alertness. Hand expressing milk can entice Lily. This also promotes having the milk ready at the nipple so Lily can spend her energy ingesting the milk. For Lily's protruding tongue, gently pushing Lily's chin down while latching opens the mouth more and promotes the tongue to go down rather than out. You can promote breast emptying by educating about the importance of a proper latch and regular feeds. Teaching breast compression can help the breast empty and increases the milk that Lily gets. Teaching Sarah about hand expression and pumping can also help. Starting breastfeeding on the affected side can help empty the breast, just in case it's too painful for Sarah to carry on breastfeeding on that side. It is important to use the unaffected side as well, though, to prevent bilateral mastitis. Administering prescribed antibiotics helps fight the bacteria. Advise Sarah to take the full prescription, usually for about 10 to 14 days, even if she is feeling better. Also assess for thrush, as yeast infections often occur when on antibiotics. For nipple healing, teach Sarah to express breast milk onto the nipples and air dry. Once the nipples heal, the portal of entry is gone. Continue to assess if the redness and pain are decreasing. Administer analgesics and antipyretics for discomfort and fever. Sarah can use cold compresses on her breasts in between feeds to reduce pain and inflammation. Drinking fluids and getting lots of rest is essential to healing, and loose clothing may be the best to avoid constriction. Outcomes. Sarah is discharged after a couple of days. Her mastitis is clearing and her vitals and labs are within normal ranges. She is to continue taking the antibiotics at home. Lily is latching better now. Although there is still nipple discomfort, the pain is decreasing. Lily's output has improved and the tactics to make her more alert have worked. Now you evaluate the care you provided. Did the support provided help the mother-infant dyad with the challenges? Yes. Sarah and Lily are improving with breastfeeding and the mastitis is clearing. Is there anyone else that should be involved? A lactation consultant can help the dyad continue to breastfeed successfully at home. Consulting a public health nurse for follow-up may be beneficial for Sarah and Lily. Although Sarah has some support at home, offering a social worker consult may help as well. In conclusion, to help mastitis, antibiotics are often used. Frequent and regular feeds and complete breast emptying are all essential when healing from mastitis. For breastfeeding an infant with Down syndrome, it's best to promote alertness before a feed. Use the dancer hold for low muscle tone, and remember that breast is best.